So Peter, over to you.
Thanks very much. So good morning, everyone. My name is Peter Currie. I'm here today to present my poster, which aims to assess the quality of online information on epidural anaesthesia in labour. So epidurals are becoming increasingly common in labour. However, frequently women are consented mid-labour whilst under a lot of physiological and emotional stress. Some surveys have found that this consent was impaired and found that risk recall was improved by educational leaflets given out prior to labour. The modern day population, however, commonly access healthcare information online, and therefore we conducted a study to assess the quality of online information on this topic. So we searched Google, the most popular internet search engine worldwide, with 3 terms relating to epidural anaesthesia, and we included the first 30 websites from each of our 3 searches. And after excluding websites such as scientific publications, websites requiring subscription, newspaper articles, we identified 32 websites in total. We used the Discern instrument to assess the quality. So the Discern instrument is a validated 16-item questionnaire which assesses the quality of written healthcare information. Each question is scored out of 5 points. So 5 says that the question is fully answered, 1 point is that the question is not answered, and 2 to 4 points if the question is partially answered. 3 independent reviewers assessed each website, and the mean scores were calculated and are shown in the table on the poster. We also assessed inter-reviewer reliability using Kendall's coefficient of correlation, which was found to be 0.79, suggesting fair concordance between the reviewers. So we found overall the quality of online information on epidurals was highly varied, with scores ranging from 31 to 75 out of a total of 80. Most websites scored well on questions regarding risks and benefits, however scored poorly on questions about sources of information, alternative treatments, and what would happen if no treatment was used. And then we also did a subgroup analysis comparing public healthcare providers to other websites, and found no significant difference between the scores. So in conclusion, more should be done to develop high quality online healthcare resources on epidural anaesthesia to reflect modern day reading practices and improve the understanding of patients, allowing a more collaborative decision-making process. Thanks for listening.
Excellent, thank you very much indeed. And up next, we have this poster.
Hi, Ashling is my name, and this is an audit that I did last year in Australia between the cardiothoracic ward and the acute pain service. So as we all know or can surmise that pain following cardiothoracic surgery is notoriously common. It can be classified as moderate to severe in up to 75% of patients. Why do we manage pain? Well, it decreases acute and psychological stress on the patient. It's a humanitarian right. It decreases the risk of acute on chronic transformation, as well as also being inherent to post-operative rehabilitation by decreasing morbidity, hospital stay, and then in turn cost. So the aim of the audit was to assess whether we were treating pain on these patients, identify patients who would benefit from a specific referral to the acute pain service for potential intervention or multimodal analgesia, and whether we were adhering to the guidelines we already had, and then the co-prescribing of laxatives and antiemetics, of course, in the use of opioids. So there were 20 cardiothoracic patients on the ward. We audited all these over a 3-week period. We looked at the medications prescribed, and these included regular PRN medications as well as stat or phone order medications given by the doctor on call. And we looked at the time that these medications were given and the time the co-reported pain score. So out of the 20 patients audited, there were 15 cardiac, 5 thoracic, 100% were charged for paracetamol, which is according to NICE guidelines now, which states that all post-operative patients should be charged for paracetamol regardless if they're reporting pain or not. One of these patients was surprisingly controlled solely on paracetamol. You have a breakdown there on the right of the regular medications used and the PRN stat medications used. So the regular medications included paracetamol, pentothal slow release, pregabalin and Targen. The Targen was found in 2 chronic pain patients who were presented with an underlying malignancy for thoracic surgery. And then the PRN stat medications were tapentadol, intermediate release, buprenorphine, oxynorm, and hydromorphone subput. So there were 2 patients with notoriously poorly controlled. One was a thoracic patient. In general, thoracic patients reported much higher pain scores throughout, which is also known to us. And one of these patients was a chronic pain patient. They just required a lot of breakthrough analgesia, and their pain scores were never less than 5. So the average pain score amongst these patients was 2.21. 6 of those had pain scores over 5. And 83% of those 6 patients had settled their pain score, and so reduction of up to over 3 after breakthrough analgesia. 70% had regular laxatives prescribed, and 50% had 2 antiemetics, and there was no sedation or any opioid toxicity reported. So in conclusion, it was quite reassuring that 90% of the patients were actually well managed on the ward. This was a relief for the acute pain service. We must acknowledge that post-operative analgesia must be preemptive and multimodal. So to highlight to our cardiothoracic colleagues that thoracic and chronic pain patients may prove more difficult to manage, and as well to highlight the option or avenue for an acute pain service referral for potential PCA or epidural, or as well as some multimodal analgesia. And just to highlight in the post-operative care pathway, this APS referral and of course the regular laxatives and 2 classes of antiemetics. Thank you.
Thank you very much. Excellent. And is our next poster?
Hi, yeah, I'm Eva Corcoran, and today I'm presenting the case of a 7-year-old woman who presented acutely in the 14th week of her 9th pregnancy with a catastrophic hemorrhage or intracerebral hemorrhage. She was on holidays in France at the time. She was previously fit and well, a school teacher, and she was transferred to the local neurosurgical centre where she underwent craniotomy, clipping of her aneurysm, repair of her AVM, and an EVD insertion, which you can see from the scans on the bottom left-hand corner, was a little bit too far inserted. At 18 weeks, when she was a little bit more stable, she had a tracheostomy formed, and a discussion broached about her transfer back to Ireland, where she's currently or normally resident. There is no combined obstetric and intensive care unit in Dublin, where she's from, and the decision was made to transfer her to our hospital, which was Beaumont Hospital, which is a level 3 neurosurgical centre with intensive care facilities. Her pregnancy continued once she was transferred uneventfully. It was complicated by the usual problems that we see in pregnancy, such as gestational diabetes, recurrent UTIs, anemia. And she also had a slightly macrosomic fetus with an unstable eye. Her pregnancy was further complicated by her initial neurological insult. So she had pyrexia of unknown origin. She had developed healthcare-related infections, and she was developing contractures. She was very intermittently agitated with a GCS, which remained fluctuant between 9 and 11. And she also had her tracheostomy, which required a lot of intensive care. It became plugged off a couple of times, and then periodically she required some extra ventilation via the tracheostomy. Regardless, her pregnancy continued, and at 34 weeks, a decision was made to deliver the baby, who was still lying unstably. Her previous 4 term pregnancies had been delivered spontaneously at term with no anaesthetic involvement via a spontaneous vaginal delivery. And the concern was that in our hospital, she may deliver out of hours or with no help present. So we made the decision to deliver the baby just before 34 weeks. It was a combined effort. There were obstetric teams present from the Rotunda Hospital and also pediatric teams from the neonatal unit, which both were off-site and had to be coordinated to be present on the day. And then, of course, there was the neurological involvement, the neurosurgical involvement, and the anaesthetic involvement in our hospital. The anaesthetic was uneventful, so she was induced via intravenous anaesthesia, which was maintained then with sevoflurane via her tracheostomy. Baby was delivered after 60 seconds, and she was vigorous at birth and given to the care of the paediatricians. The cesarean section continued uneventfully, and she was given opioid and non-opioid analgesia, bilateral tap blocks via ultrasound, and then at the end of the case was transferred to a tracheomask in recovery. The baby was transferred to a neonatal unit where it remained for a week or two and then was discharged home to the care of her family. Our patient's care continued. She was decannulated and then subsequently transferred to the Neurorehabilitation Centre in Dunleary in Ireland. And she continues to undergo intensive neurorehabilitation there. This case highlighted to us the need for a difficulty in caring for a patient such as her who had complex needs but needed multiple discipline involvement, and the need for guidelines to aid further cases, which we believe will become more common as maternal age increases and complex deliveries become more common. You can see in the bottom right-hand corner, this was quite an event and it attracted attention from all over the hospital. And the emotions ran high, as you can imagine. But ultimately, we had a successful outcome with the delivery of a healthy baby. And so it was a successful case.
Excellent, thank you. So our next poster, before Niamh starts, can we ask everybody else to mute their microphones when they're not the principal speaker, because otherwise you pop up in camera. Thank you very much indeed. So Niamh, it's over to you next.
Hi, good morning everyone. I'm going to present my abstract titled The Exposure to the Specialty of Anaesthesia in Irish Medical Schools. Of course, anaesthesia is one of the largest hospital specialties in Ireland and includes huge areas such as theatre anaesthesia, critical care, pain management. But despite this, certainly from personal experience, I found that the amount of clinical exposure to anaesthesia that medical students receive during their training remains extremely minimal, considering the breadth and scope of the specialty. So with this project, my colleague and I wanted to really quantify the amount of clinical exposure to anaesthesia that Irish medical students get. We also aim to understand how this might eventually influence their decision with regards to choosing a medical specialty. So we used a 10-part questionnaire that we disseminated among junior NCHDs. We primarily targeted interns and junior SHOs who hadn't yet made their final decision about what specialty they wanted to do. So the questionnaire asked participants to exactly detail the number of days or weeks of anaesthesia and ICU placement they experienced. We also wanted to understand what their understanding of the specialty of anaesthesia was like. So our respondents, there were 46 in total, and they represented all 6 of the medical schools in Ireland. Amazingly, 67% reported that they experienced less than 7 days of clinical exposure to anaesthesia throughout their entire medical school. 59% said that they had just 0 to 2 days of ICU experience throughout the entirety of their degree. And unsurprisingly, as a result of this, 57% of the participants felt that they did not have a good understanding of the specialty of anaesthesia by the end of their degree. So less than 9% of those surveyed selected an anaesthesia post when they were applying for their intern year. But a huge 61% indicated that they would have been much more likely to choose either an intern role or have further interest in an anaesthesia scheme if they had received more clinical exposure throughout their degree. So there are a number of reasons identified by the participants for a poor understanding of anaesthesia. And these included primarily too little exposure to the specialty, 59% saying that that impacted on their understanding of the specialty. Also too few lectures on the specialty, the fact that anaesthesia very rarely features as a big examination topic, particularly in final year throughout medical school, and also a poor quality of teaching on anaesthesia in medical school. So there's a number of other studies that kind of back up this idea that the more exposure you get, the more interest and the more people applying for these roles in hospital. So the results of our audit really demonstrate that in Irish medical schools, the influence that clinical placement has on medical students' understanding of anaesthesia suggests that a better emphasis on anaesthesia teaching in medical school might inspire further interest in a future career in the specialty. Thank you.
Brilliant, Niamh, thank you. Next. Oh, apologies. There we go.
Hello, I'm Jo, and I did an evaluation of anaesthetic services for fractured neck of femur patients, in particular looking at meeting the best practice tariff criteria. For those that don't know, this was a tariff that was introduced in the early 2010s to improve the standards, outcomes and cost effectiveness of care for fractured neck of femur patients. And how it works is that each case gets the trust a base payment, and then if they meet all the standards for the best practice tariff, they then get an additional bonus top-up payment. And my particular trust lost quite a lot of money for not meeting these criteria. And in particular, we were looking at the standard number 1, which is for each patient to have a time to theatre less than 36 hours. So I used a spreadsheet of secondary data to calculate the number of times each standard was missed for each case, and that as a percentage of the total number of cases. I also looked at the reasons for delay to theatre, whether it was lack of space, delay in orthopaedic diagnosis, or delay in time to theatre due to needing medical investigations and optimization. I then also looked at how many cases missed the additional funding criteria for just theatre reasons, other reasons, or both theatre reasons, and we then also made some recommendations with a view to implement these and re-audit. So the results were quite interesting. 54% of the cases during a year did not meet the bonus funding criteria, and the average time to theatre in those cases was 59.8 hours. And by far and away, the most commonly missed standard was the one regarding theatre time within 36 hours. In fact, 3/4 of the cases which missed the BPT criteria were due to just theatre reasons only, and a further 14% missed both theatre and non-theatre standards. So in only 10% of the cases was theatre time not an issue. And then looking in a bit more depth at the reasons for theatre delay, in 3/4 of those cases, it was due to a lack of time and space in theatre. And looking at the documentation in the notes, it was clear that this was mostly because of more urgent and emergency trauma cases taking priority over the fractured neck of femurs, because the trust itself is a major trauma centre. And then there were some delays in orthopaedic diagnosis in 10%, and 16% were delayed by medical optimization. So overall, it was quite clear that most cases were not meeting the funding criteria because of delays in theatre time resulting from a lack of space. So our recommendations focused on these, such as increasing the number of trauma operating theatres, to consider designated theatres for fractured neck of femur patients. And the actions we've taken so far are to implement an additional 1.5 extra theatre days per week, a designated trauma coordinator to organise the lists and to make sure patients have all their investigations and optimisation done to make more efficient turnarounds and more efficient running of lists. And each list will start with a golden patient, which will be a patient who's had all their tests and optimisation, and they are ready to go at 7 a.m. in the morning to prevent delays in starting the lists. And there's also now funding available for a clinical fellow to help with running these theatre lists efficiency. And so we look forward to re-auditing and re-evaluating the performance once all these recommendations are implemented. Thank you very much.
Thank you, Joe. Thank you very much. Then we have Shameek. Oh,
Yes.
Done it again. Sorry about that, Shameek. There we go.
Hi, good morning, everyone. So we did an audit on the effectiveness of the Abscess pathway in improving emergency theatre efficiency. The audit was in Bedford Hospital. So the emergency theatre utilization was audited in 2017, and it became apparent that theatre use in the early hours of the day was very sparse, despite cases being regularly booked. Reasons for this included surgical unavailability, pending anesthetic and surgical review of patients, and booking order conventions. In light of this, a pathway was proposed to operate general surgical abscesses first thing in the morning and utilize the emergency theatre more efficiently. So the question arises, why cutaneous abscess? Because cutaneous abscesses are a common cause of hospital admission and often require incision and drainage under general anesthetic. These cases often get deferred as more urgent cases are present, leaving the patient unnecessarily fasted or retained as inpatients overnight, rather than being managed as a day case. And according to NCPOD, a cutaneous abscess should be incised or drained within 24 hours of the decision being made. So the aims of our audit was to assess emergency theatre utilization between 8 and 9 a.m. in the morning, to make recommendations for utilization of any unused morning theatre slots, to reduce delays in management of patients presenting with abscess requiring incision and drainage, and to re-audit to assess any improvement. So during the cycle 1 of the audit, we use the data collected from the electronic theatre systems during the whole of 2017, and we found that only 31 patients were entered the anesthetic room between 8 and 9 a.m. and out of them none were cutaneous abscesses. Based on this data, abscess pathway was introduced in consultation with surgical anesthetic departments and the theatre team leaders, and standard operating procedure of our abscess pathway was formulated, where patients, once they come in the night before with an abscess via emergency department or a GP surgical referral, must be seen by the surgical and the anesthetic team, and if there are no red flags, they can be sent home with an instruction leaflet to come back the next morning at 7 a.m. and to be operated between 8 and 9, and the patient hopefully get discharged later that day. After the action plan was formulated, we re-audited during 1st of June to the end of September. There's 4 months in 2019, and we found that there was a 3.9 times increase in theatre utilization time between 8 and 9 a.m. So the numbers are 43 patients entered the anesthetic room between 8 and 9. Out of them, 19 were abscesses. However, there was not much of an improvement between the numbers of patients who had drainage of abscess on the day of admission and the pre-op and the total length of stay. So the deficiencies that we kind of pointed out after the second cycle was that there needs to be better communication between the surgical and the anesthetic and the theatre management teams. There was issues with transfer of notes from the emergency department and to the day surgery ward, which needs to be looked into, and there needs to be a consensus within the anesthetic department to review the patients before they are sent home from the emergency department. And we plan a further PDSA cycle in due course so that we can ensure the sustained change in practice and continuous improvement. Thank you.
Excellent, thank you. Next presenter, please.
Hello, I'm Tom. I'm an anaesthetic registrar in South East London, and this is a quality improvement project that started back in 2017, primarily just looking at positioning for neuraxial blocks in the obstetric setting. So it was noted that positioning, of course, is essential for spinals and epidurals, and it was really quite frequent that we're struggling to get a good position on these patients. There's a large proportion of ethnic minorities, so there's often a bit of a language barrier, and of course there's often issues with pain and anxiety and lots of distractions. So essentially what we did was survey patients post-operatively when they've had an operation in the obstetric theatres, and really just ask them about their experience of finding the correct position for a neuraxial block. So unsurprisingly, a large proportion of them were sort of given verbal instructions about how to position themselves. We didn't have any sort of visual aids at the time, so unsurprisingly, none of them were sort of shown this. And a large proportion of them were sort of saw a demonstration by the anaesthetist or another staff member, or had their position sort of physically adjusted. And interestingly, sort of 90% of patients were extremely anxious about getting the correct posture, which I suppose is not unsurprising when we sort of consent them for nerve damage and so on and so forth. And about 2/3 of them thought a visual aid would be useful. So we essentially introduced this diagram that you can see in the middle of the poster, really just very simply just demonstrating the correct position that we were hoping patients would get into. And we introduced this into obstetric theatres and also onto the epidural trolley on the labour ward as well. And then after a period of time, we then re-audited to find out what the patient experience was and also what the staff experience was as well. And a large proportion of patients felt that they adopted the best position after seeing that diagram. And most of the patients found it very helpful. When we looked at the theatre staff, so we got quite a good spread of different staff members, including so various grades of anaesthetists, some of the theatre nurses, as well as midwives and theatre support workers. We got sort of 41 respondents for that survey, and essentially just asking them about their experiences of using the visual aid. And 83% found the visual aid was useful in achieving the correct position, and sort of frequently cited reasons for finding it useful were that it saved time, it helped overcome language barriers, and it generally made the block easier to perform. And it's sort of become even more essential since COVID and having more in the way of PPE, which obviously makes position sort of communication much more challenging. So essentially, this is a quality improvement project. It's a very simple intervention of just introducing a visual aid, and we found that patients generally like it, and staff members find it very useful for positioning for neuraxial blocks. Thank you.
Thank you very much. Now we have next presenter, please.
Hi. Yep. So I'm Peter. I was presenting earlier, and I present another poster that I did, which is a systematic review we conducted looking at the incidence of ocular injury with prone positioning in critical care. So prone position alongside lung protective ventilation have been shown to improve outcomes in critical care patients with acute respiratory distress syndromes. It's obviously particularly topical at the minute with ongoing COVID-19 pandemic, with increased rates of patients with ARDS being admitted to intensive care units around the world. There are a range of potentially avoidable complications associated with this, including ocular injury and vision loss. Commonly, this occurs due to prone position causing pressure injuries and dependent edema to the face, and is managed by frequent head turns and good nursing care. So we conducted the first systematic review and meta-analysis of ocular injuries, comparing prone and supine position in critical care. And we searched online databases with the terms prone and position and found 11 studies with a total of 2,247 patients, with 1,089 in the prone group, and 1,089 in the supine group, and 1,158 in the prone group. So we find the incidence of ocular injury was 1.12% in the prone group and 1.19% in the supine group. And we then recalculated the incidence after removing reports of eyelid edema, as this is recognised to be sort of a transient phenomenon associated with prone position. And we found rates of 0.17% in the prone group and 0.18% in the supine group. And all of those injuries were subconjunctival hemorrhage. So there was found to be no significant difference between the two groups, either with or without the inclusion of eyelid edema. So to gain a bit more context, help us to interpret this, we compared this to rates of ocular injury with prone position for other reasons, such as for general anaesthesia. We found a large study by Yu et al. From 2010, which found a 0.08% risk of perioperative ocular injury in prone position, which is lower than the rate that we found in our systematic review. Prone position in critical care may have a higher incidence of ocular injury due to longer time periods in prone position and hypocoagulable states. So in conclusion, we didn't find a significant difference in the rates of ocular injury between prone and supine position, although the rate in critical care was higher than that in general anaesthesia. I would recommend that this data be used to guide critical care follow-up services where injuries that are not initially apparent may become apparent later on. Thanks for listening.
Thank you. We've got Niamh back now, please.
Hi, I'm now going to present an audit we did titled The Use of Peripheral Nerve Stimulators in University Hospital Galway, which is my current centre of work. So we know the current AAGBI guidelines recommends that the use of peripheral nerve stimulators is mandatory for every patient who receives neuromuscular blocking drug. So we looked at auditing the adherence to those guidelines at University Hospital Galway. In order to do that, we assessed the amount of physical peripheral nerve stimulators that were available to trainees in theatres here. And we also sought to understand human factors which might contribute to inconsistent or infrequent use of nerve stimulators among anaesthetic trainees. Our aim with this was to highlight ways in which perhaps routine use of peripheral nerve stimulators could be improved upon and encouraged in the hospital. So the first part of this involved physically identifying 22 areas in the hospital where general anaesthetic might frequently be administered. And we then located whether or not there was a peripheral nerve stimulator in the room, and if there was a kind of designated area where one might find them. In order to understand the trainees' point of view of the use of these stimulators, we employed the use of a 9-part questionnaire that we disseminated among the 41 NCHDs in the hospital, and we had 63% of those responding. So the results of the kind of physical trip to each of the theatres showed that only 4 of 22 theatres had a train of 4 stimulator available. 8 of 22 had an NMT stimulator. 4 of those 22 did have an NMT cable, but there was a part of the machine missing, namely the part that connects the stimulator to the anaesthetic machine. And 7 of 22 had no nerve stimulator located within the theatre whatsoever, despite neuromuscular blocking agents frequently being administered to these theatres. In terms of the results from the questionnaire, 69% of NCHDs in Galway indicated that they were not confident about where exactly to find nerve stimulators in theatre or who to ask if they needed one. 42% of the NCHDs surveyed agreed that they only use nerve stimulators for very few cases, and only 4% said that they use them for every single case where a neuromuscular blocking agent is given. 88% reported that the absence of a nerve stimulator in theatre was evidently the most common reason for lack of use. The next most common reasons in descending order for why these don't seem to be routinely used is that 42% of the trainees reported that they felt the use of Sugammadex often totally negated the use of a peripheral nerve stimulator. Another 15% said that it was too time consuming, and only 4% said that they had a lack of confidence about how to use either the train of 4 or the NMT stimulator. So at present, this audit showed that the use of these stimulators is not routinely employed following neuromuscular blockade. The main reasons for that being lack of access and the increased use of Sugammadex in the last year or so. We've already looked at implementing improvements in this area. So we have got in touch with the consultant lead and the bioengineer for the hospital and spoken about having training days on the use of these stimulators, also having laminated instruction manuals next to these stimulators in theatre, and also having a designated area to go to where these stimulators will definitely be kept. Thank you very much.
Thank you very much indeed, Niamh. Thank you.